On behalf of the Community Health Impact Coalition, I'd like to thank you all for joining us this morning for this very important convening. Securing the future with proCHWs, a timeless investment in health for all. For those of you that don't know, CHIC is a team of CHWs and allied health professional organizations working in over 60 countries. And we've come together to ensure quality care for all, including those who provide it. And we believe that we get there by making professionalized community health workers a norm worldwide. I would like to extend a warm welcome to the Ministers of Health and government officials that have joined us today. We're honored to have representation from Myanmar, from the Democratic Republic of Congo, from Mozambique, from Uganda, I believe from Zambia, Kenya, Tanzania, Zanzibar, and Sierra Leone. Thank you. It means a lot that people have taken time to be here this morning with us. I'd also like to welcome colleagues from the Africa CDC, from UNICEF, from WHO, USAID, Gavi, the Global Fund, and the Gates Foundation. I see a lot of familiar faces in the room, but for those of you that don't know me, I am Emily Bancroft, the CEO of Village Reach. And I'm joined here, who you'll hear from in just a minute, by my colleague, Rishit Nagar, the CEO of CHWs. Village Reach believes in the power of community health systems, and undeniable evidence shows us that when CHWs deliver primary health care in a way that improves access, increases equity, and saves lives. And we know that professionalized CHWs are critical to reaching universal health coverage and ensuring that everybody has the health care they need and deserve. We, Village Reach, joined CHIC a number of years ago because we're obsessed with increasing access for the hardest to reach communities. We help governments build responsive primary healthcare systems that adapt to shocks and stresses, that bring products and services where they need to be when they're needed, and that also respond to community needs and preferences. And there's no better people, no more important investment than the investment in the community health workforce to make all of those goals happen. I see over and over again in my work that nobody understands communities as well as community health workers, and you'll hear from a number of them today. But I want to tell one quick story, which is about a community health worker named Maxine Caduello. He's in Malawi in the Balaka district, Ziwe Health Zone. And Maxine actually started as a security guard for Village Reach about 16, 17 years ago. And we really saw in Maxine this incredible connection to people. And so we helped him finish his education, get his training, and become a community health worker. And every time I visit Maxine, the community has invested more in him. So the first time they had built him an open shelter where he could provide care to children under 5, provide reproductive health services, deliver immunizations. In Malawi, CHWs do all those things. The next time I came, they had built a brick structure for him. And then when I was just there in May, the government had actually opened up a new health post in his area. And I think this shows the power of that connectivity between community needs, community health workers, and the government health systems that support them. And so, this shared mission of getting CHWs the salaries, the supplies, the supervision that they need, and all of us working together to do that is so important. So let me now hand it over to Rishit, who will share a little bit more about CHWs' work and his perspective on this.
Thank you, Emily. So thank you all for having me. My name is Dr. Rishit Nagar. I'm a practicing resident physician here in the US, but I'm also CEO and co-founder of CHWs. We build digital health platforms for community health systems, and we work in India with over 70,000 community health workers. And we try to build tools to help them better deliver services at the last mile, to better highlight the inequities that they observe within their communities, and to overall support their growth and development. We've been around for 10 years and spent 250,000 hours co-developing solutions with community health workers in the field. And when I go to the field and I meet with ASHAs, accredited social health activists like Bharti, she tells me that she is so excited to have the job to be able to work and deliver impact within her community, but at the same time, she still spends 50 hours a month on data reporting related tasks. And she wonders when she'll be unencumbered to actually deliver the services that mean so much to her, and when the data that she reports will actually connect back to the resources that can improve her community. So for us, joining the coalition has been about moving the needle forward to empower community health workers like Bharti at scale. And we know that these community health workers can deliver on the promise of public health impact. And collectively at the coalition, we still see that there are two great injustices that are getting in the way of delivering health for all. First, over half of the world's population still lacks access to essential health services. And second, millions of CHWs are still disconnected from the formal health system. They are unpaid, unsupervised, and unequipped. But what if a single policy change could revolutionize the way that healthcare is delivered? Today, we're going to hear from a lot of experts about the transformative potential of the idea of salaried, skilled, supervised, and supplied CHWs. And for more on that, I'm going to turn it back to my colleague, Emily.
Thanks, Rashid. It's incredible work that CHWs doing, and super exciting to see how it's evolved. So Rashid mentioned the revolutionary power of pro-CHW policy, but where are we today? So today, about 40 countries have at least one accredited CHW cadre. That's great, but we have a lot more work to do. We want to make pro-CHWs the norm everywhere. And because healthcare is both political and technical, we have to think about this in a systems way. So together, we have to create evidence that changes the guidelines and the policies, both at the national and international level. We need to work with our government partners and their financing colleagues and financing institutions for more and better funding. And this is what will ultimately deliver pro-CHW policy in many, many more countries. So today, we'll be hearing from leaders, we'll be hearing from frontline CHW advocates, we'll be hearing from visionary policymakers, we'll be hearing from forward-thinking donors and funders in this space on how we can actually do this. But I now want to turn it over to an amazing speaker and an amazing advocate, Mrs. Margaret Odera. Margaret is a community health worker in Kenya, in Nairobi County. She's an organizer, she's a fierce advocate, and she is a leader here at CHIC. So thank you, Margaret. Over to you to carry things forward.
Thank you so much. It's such an honor to be standing here in front of policymakers and funders. I am a proud community health worker from Kenya and a CHW advocate. I'm here today with some CHW advocates. They are my colleagues. Please stand up and just say hi to the people kindly. It's such an honor. Now to my story. My story began, as many of you know, with a personal tragedy. I contracted HIV and lost a child. Throughout this time, I avoided the support of a local mentor mother. I felt like I had a death sentence, but the mentor mother persisted. She regularly reached out to me, helped me to change my life. Now I do the same to the people in my community. I have been doing this for 15 years. I juggle motherhood with my work at the local hospital and with my advocacy alongside you all. In all this, I don't feel tired. I have passion for all my patients, for my community and my fellow community health workers. As CHWs, we are the backbone of health systems, particularly in underserved and hard-to-reach areas. We are trusted, we are known, and we understand the cultural context of our community. we are often the first and sometimes the only link our communities and our health system can have. Every day, CHWs across the world ensure that families receive essential services such as vaccination, maternal care, disease prevention, and education on nutrition and hygiene. As much as we love our work, we are often under-supported. In many countries, CHWs operate with little or no pay at all, inadequate supervision, and minimal supplies. In my own experience, I have seen firsthand on how lack of inadequate supplies, such as gloves, medicine, or simple first aid kits, can hinder ability to save lives. The lack of formal recognition and fair compensation also diminishes the potential of community health workers to stay in the field. Our dedication and passion can only carry us so far, otherwise we will all suffer. Globally, we are at the crossroads. We face unprecedented challenges. The rise of new health threats caused by climate change, the burden of non-communicable diseases, and the long-lasting impacts of COVID-19. So the world cannot afford to ignore or underinvest in CHWs any longer. We need a salaried, skilled, supervised, and supply CHW workforce if we are to deliver the promise of health for all. I have seen firsthand transformative impact in this support. The Kenya government's landmark recognition of community health workers has legitimized our role and expanded our reach. When the Ministry of Health began integrating CHWs into the National Health Strategy, it became easier to access necessary resources and training. Such recognition not only empowers us, but also helps us and helps the broader health system by easing the burden on overstretched healthcare workers. So thank you all of the policymakers, organizations, and CHW advocates who worked together to get us there. We see the same efforts taking shape across other countries in Africa, like Burkina Faso, where governments are realizing the value of community health workers in achieving universal health coverage. In September 2022, I began working with Community Health Impact Coalition as a CHW organizer. Connecting with other community health workers from around the world made me realize the challenges we face are universal. Finally, I'm here today with CHW colleagues, but we are just a few who came to the light. As the saying goes, if you see one, there are millions out there. Investing in community health workers is not a cost. It is a timeless investment. When we invest in community health workers, we save lives. We create resilient communities, and we build stronger and more inclusive health systems that leave no one behind. So I also ask you to pay attention to us, recognize us, value us, and work with us, because we matter and our work matters. Now it is my honor to introduce our next speaker, Dr. Nishtar, the CEO of Gavi, the Vaccine Alliance, to talk more about the crucial work of the funders in our shared missions. Thank you so much.
Good morning, Excellencies, ladies and gentlemen, friends. It's a pleasure and a privilege to be here. When I was finalizing my schedule for UNGA, as most of us do, I explicitly stated this is the one event I just want to be at. And I truly want to thank you for the honor of, for giving me the honor to be here today and to be able to speak to you about something which I think is of immense importance to global health. as a I'm 6 months into the role, not new anymore, but 6 months into the role. And when I came in, as all CEOs do, I hammered out a 6-month plan. I called it the 180-day plan, and there were 5 pillars of that plan. One of the pillars of priority was making a difference in the lives of women and children. And that stream of work had an inward-facing, a secretariat-facing component and an externally-facing component. And as far as the inward-facing component was concerned, I have commenced with tracking metrics, from pay transparency to, to the nuts and bolts of how many women are speaking on panels, how many women in missions. And on the outward-facing leg of the women and girls' well-being stream, I committed myself to joining all of you, to contributing in a modest way to doing something concretely about the remuneration of CHWs. The remuneration aspect is, of course, one aspect of a much larger ecosystem change that is warranted, that is necessary, that is urgent. It's a journey towards which many other stakeholders are quite further along than I am. I'm very much in the initial stages. But I committed myself to doing something concretely about it. Why did I do that? Because I have seen the suffering, the discrimination that my dear sister Margaret talked about firsthand. As most of you, I'm someone with I'm a physician by training, as many of you, with an interest in health systems, and by virtue of that, many of us have the opportunity to be in the field in primary healthcare settings, see things firsthand. And of course, you have a health systems perspective on things in that role. But my actual exposure to the world of community health workers actually happened when I had the privilege of serving as the Minister of Social Protection in the government of Pakistan over a 4-year duration, where I had the responsibility of delivering a very large packet of benefits to 15 million families, to 100 million people. And in that role, I had the distinct privilege and honor of having several immersive experiences where I would spend a day, an evening, 2 days in a community, and I would experience what they were undergoing. I would feel the lives that they lived. And honestly, it really humbled me every time I did that. And I saw firsthand the very difficult lives that community health workers led. Most of the community health workers in my country and in many of the countries that you come from are young women. And what I saw on the ground was that they were actually bearing a triple burden. Because many of them, some of them were newly married, some of them wanting to get married, some of them were expectant, some of them had small children. Many of them were living with very hostile in-laws who were really pushing back of them going into the field, having a life of their own. So there was that personal battle, there was that very personal battle that these young, ambitious, bright women were enduring in their personal lives. Husbands that were not supportive, oftentimes abusive, very, very critical in-laws, brothers who were not supportive of them, raising their hands and going out to work. And there was, the sleepless nights looking after children and then turning up 6 a.m. for a polio campaign. So there was this personal struggle that I saw firsthand. And then there was an external struggle in the outside world when a young woman in a country like mine, in many of in any African country that now I have witnessed, goes out to the street at 6 a.m. in the morning with a box on her shoulder, whether she's delivering immunization or whether she's delivering contraceptives or whether it's for a malaria campaign, the security threats, the verbal abuse, the inappropriate advances, and this constitutes another dimension of the lives of these community health workers. And thirdly, the sheer burden of work, the sheer unpredictable burden of work. You're pulled into a polio campaign one day, and the next day the malaria program manager raises a flag and wants you on the bandwagon, and the third day, Gavi has an outbreak response. The unpredictability of their, I beg your pardon, the unpredictability of their work life. And I compare that with our own environment, where we want a month's schedule and predictability and don't want to be disturbed on a Sunday and after 5. And these women, with this huge unpredictable burden to deliver, with an internal domestic battle that faces many ways, and with an external environment where we throw them without any protection, was one of the most difficult things that I saw. Just the 1 minute flag, just give me a minute more. It was truly humbling. And I think what is the icing on the cake? The icing of the cake is that we do not pay them. There are close to 6 to 7 million community health workers out there who are paid nothing, who are paid zero. And my sisters here will bear me out on that. And when you pay them, it is a shocking, disrespectful $10 to $20 to $30. It's outrageous. At the World Health Assembly this May, there was a young boy who stood up at the podium and put us all to shame when he said, I am sometimes paid $10 a month for the work that I do for all of you. And I think this should be a huge wake-up call for all of us. So this is a long-winded way of saying this is not just an experience from Pakistan. It's an experience from every country that I go to. It's the same story over and over again. And clearly, there's a very broad-ranging agenda, in the policy side of it, the recognition, the formalization, making sure that they're not treated as volunteers, because in many countries, community health workers are treated as volunteers just because governments do not want to make sure that they come within that bracket of the minimum wage, because that imposes an obligation on their part to pay for them. So what I'm saying in the extra 1 hour allocated to me very kindly is that we must do something very, very seriously about it. I know that there are colleagues who are far further along this journey than I am, and I know that Atul is one of them. So perhaps this is a good segue for me to step down and give the floor to him, but with this commitment that I stand ready to contribute in whatever way I can in my personal capacity and on behalf of my organization. Thank you so much for the privilege of having me here.
Hello and welcome. I'm Atul Gawande. I lead global health at USAID. I get to moderate our opening panel, and thank you for those rousing at 7:30 in the morning, 8 o'clock in the morning comments to get our UNGA started. I would like the ministers who are on the panel to go ahead and join us here on the table on the podium, along with we have a CHW partner and a CSO partner. So if we don't mind going ahead and joining us on the stage. Shall I call Dr. Jane Ruth Cheng, please, and Dr. Robert Lucien Kargugu. I believe I don't see, we have one other minister as well, Dr. Austin Demby. I don't see Minister Chaponda. Ramatu Jallo, thank you, Ramatu, and Ari Johnson. While they're assembling, I will say a few words of introduction to say. A year ago at the World Health Summit in Berlin, I helped launch, together with Chick and my colleague Margaret O'Dara, who you got to heard speak earlier, the Community Health Delivery Partnership, joining together many of our countries, organizations, NGOs represented here. And this initiative champions a country-led, data-driven approach to identify the policy and program actions to advance national priorities and to aim to support community health workforce and the primary health care workers in our communities. The goals included advancing the status of community health workers, their rights, and their labor protections. As countries grapple with increasing and now simultaneous crises, we lean on community health workers. You heard the way that Sonia Nishtar laid out the personal experience. We have all who are involved in the crises that we take on seen that we are expecting more of community health workers. We want them to have more skill, more training, to do more outreach and provide more availability. But as we expect more, we also have to support them more. It cannot be possible to make it all happen. And so with that, advancing our policy frameworks to protect healthcare workers' rights, promote decent work, have inclusive, fair remuneration and occupational protections, offer PPE as we ask them to follow up on outbreaks, for example. These are basic things that we have to be able to build towards. We know it's a journey, but it is urgent. And so effectively designing CHW programs that not only support the health workers, but integrate them into our health systems, make the connections from the household and community to the clinic and beyond, and then back again as they support the journey of the patient and the health of the patient. These are key to advancing our health goals, including universal health coverage. And so I'm honored to be here today with this coalition and our esteemed panelists to reflect on the progress we've made so far and the work still ahead to ensure that community health workers everywhere can be salaried, skilled, supervised, and supplied. After all, that's what we know it takes for the collective vision of quality health for all. So it's my privilege to have on the stage our colleagues, the Minister of Health of Uganda, Honorable Jane Ruth Acheng, the Minister of Health of Burkina Faso, Dr. Robert Lucien Jean-Claude Cargagou. We have Honorable Dr. Austin Demby, Minister of Health of Sierra Leone, Ramatu Jallo, CHW and partner from Partners in Health, Sierra Leone, and Dr. Ari Johnson, CEO of MUSO. I will ask you to have your translators, because Dr. Cargagou is likely to be speaking in French. And we will spend around 25 minutes or so talking with our panelists, and then close with questions from the audience. Thank you to everybody gathered here. I'd like to start by hearing from some of our panelists on community health policy in their countries, and I'm starting with Minister Acheng. Minister, you have been in the midst of a new policy, introducing community health extension workers, CHWs, as a professional group. And you are making government investments and financing plans for their support. Can you share a bit about how you are building political will and securing domestic commitments and investment to support the new policy?
Thank you very much, Dr. Tool. Good morning to you all. Uganda started the concept of community health workforce in the year 2000. And at that time, we had a special group called the village health teams that, of course, were largely voluntary. But these were put in place with a policy and a strategy and great support from government as well as the head of state. They did a good job, but as we have heard from the previous speakers, there is a limit to voluntarism, and that cannot go on forever. So in 2014, we started a new agenda. We developed the community health extension worker policy. And in this policy, we were very determined to ensure that the community health extension workers are remunerated. They are supported with all that they need in the field to do their job, including transport, the VHT kits, that includes a bag, and the medicines that they need. But also put in place a community health extension worker electronic system for them to capture data and remit this data to the districts and to the center so that we know exactly what they are doing. And they are running their work through what we call a household model. So this strategy, the policy and strategy were approved by government, and it is headed by His Excellency the President, because we believe that 75% of our disease burden is preventable, and all these issues start in the community, and the communities are better placed to handle them. We have seen this evidence from the various outbreaks that we have, and it is the communities that handle them. We also have a national community engagement strategy that captures the aspects of the CHWs, because the CHWs cannot work in isolation. There is a bigger community component that we are aware about, including health promotion and education and so on. And the CHWs are part of that. So our community health extension workers are paid $50 per month. It is not a salary, it is an allowance. Because in Uganda, we have the entry point into civil service. Without those qualifications, you cannot join the civil service to get a salary. So we are working on the career for community health extension workers. Thank you. I hope I haven't exceeded the time.
That was excellent. Many thanks, Minister Acheng. You covered many things, including some of the challenges of the formal salarization of health workers, but also the ways we've leaned on them. And I got to see with you on the Sudan variant response in person how critical that door-to-door capacity is and their increasing skill. I want to turn to Dr. Kargugu of Burkina Faso. Congratulations on the launch of Burkina Faso's new National Community Health Strategy, which includes strong policies for professionalizing community health workers, including payment and supportive supervision. And I wonder if you could tell us about the policy change process and your leadership in aligning partners behind your plans.
Alors, merci beaucoup. Je voudrais avant tout propos vous dire merci de nous associer à cette importante activité, de pouvoir partager l'expérience du Burkina en matière de santé communautaire, qui est évidemment historique. La santé communautaire est dans la culture du Burkina parce que les premiers agents de santé à base communautaire au Burkina ont été identifiés depuis la révolution de Thomas Sankara en 1983, donc il y a de cela 40 ans. En son temps, chaque village avait une accoucheuse villageoise et un agent de santé villageois. Après, malheureusement, on n'a pas pu pérenniser cela. Mais alors, depuis 2016, le pays est revenu en force avec la santé communautaire parce qu'il s'est rendu compte de la puissance de la santé communautaire. Et donc, on a recruté 16 000 agents de santé à base communautaire qui sont rémunérés, 50% par le budget de l'État et 50% avec l'appui des partenaires techniques et financiers. Et l'an passé, le pays a encore recruté 15 000 agents de santé à base communautaire. Cela malgré la situation sécuritaire et humanitaire que vous connaissez. Et là, encore une fois, ils sont payés 50% par le budget de l'État et les 50% avec l'appui des partenaires techniques et financiers. Évidemment, tout cela se fait dans le cadre d'une stratégie de santé communautaire Donc nous venons d'élaborer cette nouvelle stratégie dans le cadre d'un dialogue fécond avec les partenaires techniques et financiers qui nous ont appuyés techniquement pour que nous puissions l'élaborer, et je voudrais saisir l'occasion pour leur dire merci. Et dans le cadre de cette stratégie, évidemment, nous voulons aller davantage vers la professionnalisation des agents de santé à base communautaire. Les 32 000 agents de santé à base communautaire actuellement sont rémunérés à $40, comme je dis, 50% budget de l'État, 50% partenaires techniques et financiers. Mais au-delà d'eux, et ils sont formés pendant quelques semaines, mais nous voulons aller vers la professionnalisation en ce sens que nous avons créé ce que nous appelons les agents de santé communautaires, qui sont formés pendant 18 mois. Ils sont formés pendant 18 mois à l'École nationale de santé publique, et eux sont des fonctionnaires. Et nous sommes en train de mettre en place un mécanisme qui va permettre de faire passer les agents de santé à base communautaire vers les agents de santé communautaires. Donc, si un agent de santé à base communautaire est certifié, il peut alors certainement passer vers le statut d'agent de santé communautaire, qui est un statut de fonctionnaire. Et donc tout ça vraiment met en avant l'intérêt que le gouvernement, la transition, montre pour les soins de santé primaire, pour la santé communautaire. Et je voudrais insister en disant que le budget alloué au ministère de la Santé est de 12% au Burkina. Et donc c'est l'utilisation efficiente de ces 12% qui permet évidemment de financer une partie de la santé communautaire. Merci beaucoup.
You make some excellent points that one I want to draw out here is that there are different cadres, as we would say sometimes, of community health workers, different status of community health workers. I was struck in Thailand where they have 1 million community health workers for a population of 70 million. And that's 1 for every 10 households. You will not salary 1 in every 10 households people. Those people are working 5 hours per week, but they touch every home on a regular basis and recognize issues. But the next level, the community health worker supervisor, is salaried, is incorporated into the minimum wage and have the civil service protections that supervises all of them. And when there's a crisis, when they recognize an unexplained fever, when there is someone who is sick or not following up on their TB treatment, they are the ones to come in and enable that capacity at that next level. And they have been crucial in bringing Thailand to now matching US life expectancy on $300 per person per year for healthcare. We spend $12,000. This is what that power of outreach and capacity can do. With that, I want to turn to Minister Dembi from Sierra Leone. Now, you've had a pro-CHW policy since 2021, and it includes accreditation, includes payment, but it has been a struggle to fully implement. And I appreciate your being here to talk about the challenges and the reality of moving these policies forward. You have won the policy. Now, what are the challenges in implementing such policies as part of a comprehensive human resources for health investment in Sierra Leone?
Thank you, Atul. As you may be aware, Sierra Leone's Masala Davis actually read the Alma Ata Declaration. And so we are embedded in primary health care from the get-go. I think we've seen clearly the advantages and opportunities that community healthcare workers provide for us. During the Ebola outbreak, we saw how important community healthcare workers are because these outbreaks start in the community, they end in the community. And if you don't have an active community team to work with and rely on just the facilities in the hospital, you lose the game before you even start it. So for us, community healthcare workers are central to all of what we do in country. I think we're also rethinking primary healthcare. looking at person-centered care and following life stages. We really want to take healthcare outside of the hospital, and have the hospital as the safety net, but actually healthcare occurring within the community. And so if you're looking at a 360 rounded support for individuals in the patient-centered care, community healthcare workers are completely indispensable in that regard. So I spent a moment telling you about the advantages and the opportunities it brings, but let me tell you some of the challenges that we confront, and perhaps the last second, look for some solutions. The biggest challenge we have is in the healthcare, hospital-based, facility-based services where we're training doctors and nurses. We have close to 15,000, 20,000 salaried staff in the regular system. We have about 15,000 community care workers. We have about 15,000 medical volunteers. So the challenge now is if you have PIN codes, that's a lump sum of employees you hire. Who do you hire? A nurse or a community care worker? I think that's the dilemma. If you go for the community care worker, the hospital staff are more organized. They've got their unions, they've got their professional organizations. They go, we've spent 3 years in training and we don't have a job. Why are you giving the government jobs to community care workers? That's the dilemma we face. And I think the solution is to be able to articulate the complementarity between community care workers and the facility-based service providers, and look for a way of professionalizing the community care workers so that their salaries and their compensation, small as it may be compared to the facility-based services, is recognized, it's important as a unit group with their supervisory structures, with their acknowledgement, because there's no way we're going to do primary health care. There's no way we're going to do outbreak preparedness and response without community care workers.
You make such an important point, because I think that much of the larger global health world does not recognize that a community health worker is not an attempt to replace the nurse or an attempt to replace the doctor. They are a team. We don't function as teams in primary health care today. But when you have a community health worker who touches every home at least once every couple months, they are measuring the child, weighing the child. They are looking at the medicines that people have and seeing whether prescriptions for HIV, TB are filled. They're recognizing a fever and being able to address, could this be malaria? Does this person need attention? Someone who's been neglected, someone who's very sick, they will not attempt to cure them alone. They will bring them into a primary health care facility, and that's how they save lives. It's the only way we get to 90% vaccination is the recognition of the few who didn't get their vaccination. And all of those steps along the way, enabling that team as part of a larger primary health care strategy is critical, and we have to help doctors and nurses to understand that as well. Ramatu, Partners in Health, you are working as a community health worker. You have heard some of these discussions. Can you tell us about your advocacy as a community health worker and the impact of it in your country and with your fellow advocates?
Yeah, thank you very much for giving me the opportunity to be among dignitaries, friends, members of health professionals. Well, as advocacy has put me in a better position to climb the ladder of participation. That has led me to be here today. Also, I have mobilized and guided more than 150 community health workers to complete their advocacy training course that's organized by CHWs. Advocacy is part of my daily job as I advocate for my community members and my patient on a daily basis. And today, me being here with my fellow CHWs is my greatest joy, because advocacy is the only tool that gives us the confidence to speak for ourselves, gives us the opportunity to speak for ourselves rather than people speaking on our behalf. So I only know that without advocacy, we never understand who we are, because our voices are not heard. But with the power of advocacy today, our voices are heard globally, and I know it's going to be a great change. Thank you.
Thank you. Ari Johnson, CEO of Muso. I wonder if you could tell us about some of your work so we can understand Muso. We heard earlier that CHWs are vital to achieving health. We've talked about the roles that they play. And then you've published Muso research that proves some of the ways we are using their capacities. Can you expand a little bit here on the evidence you've gathered and note what elements are not just critical for salaries, but for the protection and success of community health workers?
Thank you so much. Can you all hear me? Okay. What an honor to be among you. So the state of the evidence, right? We know that there are more than 100 randomized controlled trials showing us what community health workers, when they are well supported as professionals, can do, improving maternal and child health, improving maternal and child survival. The evidence is clear. Now today, we live in a time of war. There's more armed conflict in the world today than at any time since World War II. 1 in 6 children today live within striking distance of an armed conflict zone. And 48% of all child deaths in the world are happening in armed conflict zones and fragile states. So it's critical for us to understand, how do we face that moment? What can we do in the face of armed conflict? And we had some surprising results, a surprising answer to that question from a study that we had the honor to conduct in partnership with our colleagues in the Malian Ministry of Health and a consortium of academic researchers from around the world, just published this month in the Bulletin of the World Health Organization. Now, this was a massive research undertaking in which we followed 135,000 individuals for 3 years as a new community health worker, a professionalized community health worker program and primary care program rolled out across the Mopti region in rural Mali. And is rolled out by the government with our support. And, you know, what does the literature tell us about what would happen in this situation? Early in the trial, something very unexpected and tragic happened, which is armed conflict broke out. And we asked our community partners, what should we do? And they had a resounding answer. They said, you must stay, you must continue. They understood that the stakes of the research just got higher. And they were right. And usually in armed conflict zones, when armed conflict breaks out, child deaths rise. Under 5 mortality is 3-fold higher in armed conflict zones than in peaceful areas. But here the opposite happened. We saw under 5 mortality rate plummet by 63% compared to peacetime when communities had the support. When communities had the support of a professional community health worker providing care without out-of-pocket fees and supported by a robust primary care team. So coming out of this, I think this should guide us to set the bar for our own commitments and help us understand that often when we think about working in conflict zones and fragile states, we think about relief, humanitarian relief, which is, you know, when you think of the term, it's about cushioning the blow. It's about mitigation. But our community partners in this trial proved to us that that's not the right standard, that we should actually be aiming not for relief, but for equity, for making the death of a child rare in every community, including communities facing armed conflict, and that's possible when we support professional community health workers in the lead with the supports that they need and deserve. And that's exactly what the Malian Ministry of Health is doing and rolling out right now nationally with the support of many partners.
Thank you for that new evidence, which I have not been familiar with. I hope you will circulate it in this group here afterwards, and I certainly would like to see the report and the results, and it's strong work. Thank you, Ari. I'd now like to turn to take some questions for the audience, for our panel, or comments that you wish to make. I know there are a few people that have already identified themselves to me, and we'll start with those in the audience, and then see if there's additional time for questions after that. Bupe Sinkala is a CHW from Zambia, and Bupe, can I turn to you to ask your question or make your comment?
Is it on? Yes. Okay. Good morning, everyone. My name is Bupe Sinkala. I'm a community health worker all the way from Zambia. So I'm so delighted to be here this morning in New York. And I can't be here and not mention that, yes, I can't be here and not mention that we all know that change begins and ends in the community. So my question this morning to our policymakers here is that how do you propose to engage us community health workers, be involved at being at the table in a room like this, and also how do you intend for us to be there when you're making these policies and also making changes to these policies so that we are part of the discussion? Thank you.
Thank you. I wonder if one of our ministers of health might be able to answer, how have you brought community health workers to the table? She's asking, how can they be at the table? Minister Acheng, thank you. I was going to just ask you directly, but
Well, we have structures in our country on how we engage. First, we have what we call the National Coordination Committee for Community Health Workers that brings on board all the partners in the arena of community health workforce for us to discuss, develop the policies, agree on how we are going to engage them. And in this structure, we also have the community health workers that are represented. Not only one or two, but from the various regions. In addition, we have the committee that does the actual work, and the community health workers are also engaged. So their voices are heard from all over the place. In any case, they are the ones on the ground doing the actual work. So we can't speak for them. They are the ones who have to bring on table the issues on the ground for us to handle. Thank you.
thank you for that. Did you want to add? No. Yes.
Yes, thank you very much. I think for me, it's really important that there is a proactive effort at bringing community workers to the table. The challenge is that you have to have a clear voice and to be heard. So, as I said, the big tension we have is the role of the community care worker as it complements the facility-based workers. I think having a champion that would articulate and really express the value, the added value that the community care worker brings to the table is vitally important. Because the worry is that when you sit at a table now with big doctors and big scientists, and it's very easy for the voice to be drowned. And so having a champion, being able to show data and evidence of the value addition to community workers and their complementarity. It's not a replacement, their complementarity to what's provided in the hospital setting in the same medical team is really vital.
So important. The other professions have organized, and in the same way, the community health workers need to be at the table in an organized way. And CHIC is playing an important role in helping make that happen. So it's great to have this hosted here. Now I'd like to turn to Dr. Zha Wai So, the Minister of Health of the National Unity of Government of Malawi, for a comment or question.
Thank you very much. I'm very happy to hear all these your panel. You have discussed about the professional CHW, and also I would also like to thank the organizing team inviting me, and I'm here. I think you all know Myanmar, current situation in Myanmar, and the community health worker situation in Myanmar. Since February 2021, military coup, and Myanmar military junta has driven the country further into the humanitarian catastrophe. 131 healthcare workers were killed within 3 years, including 73 community health workers. And many women, community health worker women, were raped. And even, I don't know if you know that recently, UN office in the western part of the Myanmar was bombed by the military area attack. And all healthcare workers are intentionally targeted and attacked, vulnerable, and shortage. But we have been training and recruiting the community health workers. We seriously and strongly considering the quality, career ladder, and regular benefit for community health workers in our new federal democracy health policy. Actually, we are winning. Within 3 years now, we started with 0. Now we control 65% of the country territory. And that area of service, we depend on the community health workers. My question is, how Myanmar Professional Community Health Worker Program and policy can get support and coordination and sharing from the members and Community Health Impact Coalition, CHIC, CHIT. CHIT, if you translate in Myanmar language, this is love. Thank you very much.
Thank you. I think this panel may not have the answer for how we can best help Myanmar, but let me see if there is anybody who might have a way to suggest how. I wonder, Ari, if I can call upon you, because some of your data has indicated in conflict zones, and Myanmar is one of those fragile states. What are the methods that have enabled community health workers to continue to contribute? What has it taken to drive protections and advocacy when you feel most powerless, when it's militaries and it may be within a country, it may be coming from outside that country or territory, you feel most powerless?
Thank you so much. And I am particularly inspired by our ministerial colleagues in the room who are building national programs that are supporting professional community health workers even in the midst, and especially in the midst of the threats of armed conflict. We, embedded within this trial, we conducted what's called a process evaluation to really understand the how and the why of the results. And we found something very surprising there, which was after multiple years of escalating armed conflict, health workers, including community health workers and the nurses and midwives who backed them up, were actually more satisfied in their jobs than they were previous to the intervention in peacetime. And this was shocking. Our health workers were, their lives were in danger. And they described what it meant to them to be in a situation where they had the tools that they needed and deserved to care and to support themselves in the process. The power of having, yes, regular pay, regular supply, and for that with things like IEDs and checkpoints, one needs adaptations like decentralized emergency stock points, restocking points. So when roads get cut off, you can still access, right? And digital tools, a dedicated professional supervisor, and a high-quality primary care clinic and team to back you up, so you're not alone. With these things in place, they said that they're more satisfied in their role, and they felt more supported, and that actually changed, by their report and by their patients' report, how they interacted with patients. So patients described that when they had interactions with community health workers, with nurses, with midwives, they felt a greater level of respect and that they were receiving higher quality, more dignified care. And so I believe that we can design for health systems that show up for the health workers who are putting their lives on the line to show up and support all of us.
That's so important. I think we all recognize this. At one point or another, we've all been in a crisis, COVID being one that was universal, and you felt utterly powerless, except in health, where you felt you could do something. If you were part of a larger team, if you were part of a larger system where you were empowered and had some capability to offer help in your community. We all want to be useful. And in the face of devastating unknowns, that is where you start to feel purpose. I want to turn to Minister Kargugu, who wanted to add a comment on this.
Oui, juste quelques commentaires. Le Burkina étant évidemment confronté à une situation sécuritaire et humanitaire que vous connaissez tous. Et dans cette situation, les agents de santé de façon globale, et particulièrement les agents de santé à base communautaire, paient parfois un lourd tribut, assassinés parfois qu'ils ne sont pas des terroristes, qui ne souhaitent pas que la continuité des services essentiels de santé et de nutrition soit une réalité. Mais malgré ça, les agents de santé à base communautaire restent sur le terrain et quand c'est parfois extrême, que les populations sont elles-mêmes attaquées par les terroristes et donc parfois elles sont obligées de se déplacer vers d'autres zones beaucoup plus sécurisées. Les agents de santé à base communautaire se déplacent avec les populations et continuent d'assurer les services essentiels de santé et de nutrition au profit essentiellement des femmes et des enfants. Donc oui, dans les situations fragiles, les agents de santé paient un lourd tribut, les agents de santé à base communautaire paient un lourd tribut, assassinés en fait souvent par des terroristes. Mais ils restent debout, ils restent présents et ça c'est quelque chose qu'il faut véritablement mettre en avant. Merci beaucoup.
Dr. Salim Nasir Slim, Minister of Health of Zanzibar, wanted to be able to raise a question.
Good morning. Thank you very much for giving me this opportunity. I'm joining with my minister, obviously. First of all, I want to thank USAID for the support that you have managed to provide us in our community health work in Zanzibar to be where we are today. And as we speak, only about 6 weeks ago, we managed to put them in a training where they will stay there for 6 months and graduate to become professionalized so that they can attain at household level and required to do all those point of care testing to actually understand the issue at the household level by counting heads. We really privileged that community health worker in Zanzibar have changed the paradigm of seeking care, especially into antenatal clinic. Before we actually took them on, we were only having 27% of women seeking care in the first 12 weeks. And now it's gone all the way to 78, 79. And that means now if we are heading to reduction of maternal health, this should be the way forward. So we still are doubting that once they qualified and finish their training, we need to equip them with the equipment that they require to be able to do their work. And for me, the proposal is we are looking for a way and support on how we can execute that. And that's something which is in my minister's mind and also president, because them two are the one that champion this, expressing their political commitment to ensure that Zanzibar, we do actually try to remove the barrier for social determinant wealth. That's the only question I have. Thank you very much.
Thank you. I know we're now out of time. Thank you to all of you for joining. Thank you to the panel. And I will now turn it over to the CEO of CHIC while we exit the stage, Dr. Madeline Ballard.
Thank you to our esteemed panel and to our esteemed question askers. I think we'll be hard pressed to find a more high-level group having a more animated discussion this week. So my name is Madeline, or at least that's how most of you know me, because you all think I'm American. But actually, my name is also Madeleine, and that's because I'm from Montréal. I think we have a representative from the Gouvernement de Canada ici, so a wave, you're most welcome. Yes, and a clap. Montreal is actually a place that has a lot to teach us about what it takes to change systems on a global scale. And that's because of the Montreal Protocol. So you may have never heard of the Montreal Protocol, but I'll bet you've heard of the hole in the ozone layer. Ah yes, the hole in the ozone layer. Whatever happened to that? Well, back in the 1970s, scientists realized that certain substances were depleting the ozone layer, and they called for urgent global action. And so they worked together to create global guidelines. And in the late 1980s, the Montreal Protocol was established to phase out ozone-depleting substances. Now, why am I telling you all of this at an event about community health workers? Because that global guideline led in the 1990s to the creation of a multilateral fund to support countries to phase out ozone-depleting substances. And the activation of concerned citizens demanding change during that period, likely when you heard about the hole in the ozone layer for the first time, led to the universal ratification of the Montreal Protocol in the 2000s. By 2010, we had globally phased out the most common ozone-depleting substances, and we are on track to be at pre-1980 levels of those substances by the year 2070. Research to create guidelines, advocacy to increase funding, and activation of in-country networks to change national policy. Sound familiar? As a pro-CHW movement, we are well on our way to a similar victory. Our movement has had a litany of success. We have seen a groundswell change in global pro-CHW guidelines. We have seen huge momentum, where's Nan Chen, in global pro-CHW financing. And we have, as discussed just now, seen incredible, significant landmark policy changes in countries like Malawi, Sierra Leone, Mali, to name just a few. We are winning. And we are living in a time in which every single secular trend, from the pandemic to the rising tide of the women's movement around the world, to increased focus on labor conditions, sets us up to keep winning. And to do so, honestly, at an incredible pace. It took the ozone folks 20 years to get from guidelines to country adoption. We've begun to do this in just 5. That being said, as we heard from Emily this morning, the scoreboard is also clear. Right now, 40 countries have pro-CHW policy, which means that 60s do not. So there's lots of work ahead of us. And I think that one thing that we can learn from the ozone movement is that in order to win, to really, really completely win, we will need to ride out political instability, to stay focused during economic downturns, and really as a movement, to stay relentlessly focused over decades, even as new fads are popping up left and right. But we can do it. We can do it if we stay in the game and we stay together. Wartime, peacetime, boom time, bust time, community health workers are always a no regrets investment. So, if you are a funder in the room, make pro-CHW best practice a requirement for funding. If you are a CHW or aligned health organization, it starts with the PIN, but there's more to joining the movement and making your voice heard. And if you are a minister joining us here today, a policymaker, you work in government, this is your legacy project. Adopt pro-CHW national policy. Ultimately, I think the thing that we can learn from the ozone story is that real change makers don't quit. And that is essentially my invitation for you today, to become one, to stay in the game long enough to win. Together, we've been able to put pro-CHWs in the spotlight, and now it's time to make them the standard. So if we're halfway up the ladder, let's keep climbing, because the view is getting good. Thank you.